talk about value-based modifiers. And now that ACCA has been upheld, this is more important than anything. And I don't know why I'm not hearing this talked about more in the industry, except that a lot of vendors aren't doing it. Okay, so under the Affordable Care Act, CMS has to bring all these programs into alignment. We're going to move, right before we have affordable care for all Americans, we're going to become a purchaser of value. Value will be defined as a factor of quality. Quality is the clinical data you submit, and efficiency. That's the cost for that episode of care. When we look at ACCA overall, there's 3 health IT themes. The first one, and the most major one, is your federal government is taking a very big step, if you will, into defining quality. And they're doing that through quality reporting and measurement. Now, defining value or becoming a purchaser of value, all payers are interested in that. I know this because I worked for Blue Cross Blue Shield of Montana before I came to Success EHS many years ago. Everybody wants to purchase value, not just a service. The difference between your commercial payers and your governmental payers is your commercial payers cannot enact legislation and they cannot craft regulations and policy. But they sure as heck can get on board with what's going on with your federal government. So if you think you're immune because, you know, it's here, and this is where it's going to go, and now that ACCA's been affirmed, it's moving forward. So this is very, very important. So they're going to take a firm stance in defining quality. They're expanding the quality reporting on PQRS and their ACO performance measures. So that's looking at it at a community level. They want to improve quality of care with evidence-based guidelines and clinical decision support. And they want to encourage quality through reimbursement modeling. And they have established a new division of Medicare called CMMI, Centers for Medicare and Medicaid Innovation. In order to do that, they have to have uniform operating rules and standards, and we don't have enough workforce to make this happen. So we've got 2 other themes there. Now, what they're planning to do is have a linkage between the provider's performance, which is this here, and the way that they pay. And they will pay differentially, which will be known as a value-based modifier. Now, this builds upon a pilot that was started in 2009. And in 2009, they had these feedback reports. They were called resource use reporting that they gave to physicians. They added to that some claims-based quality measures just to beef it up a little bit. The resource use is going to determine the value modifier. This is going to be a budget-neutral application of the value modifier. So they're still going to pay out $10, but instead of paying $5 and $5 to provider A and provider B, they're going to pay $7 to provider A for following performance guidelines and $3 to provider B for not following them. So that's the plan. So it will be budget neutral. The way that this rolls out, there's no carrots to this. All the carrots and sticks are when the program hits. But this is why it's so important you do things like the EHR-based reporting of your quality data. So here I'm going to apply my value-based modifier, like I said, differentially. So some folks will get more money and others will get less.